Imagine looking at an 85-year-old patient who's just come into the emergency department. They have taken a massive fall, and, well, their elbow is completely shattered. You are looking at the radiograph, and the olecranon, the bony point of the elbow, is in multiple jagged pieces.
Right.
It's displaced by over a centimeter, sitting right under the skin. As an orthopedic surgeon, your absolute hardwired instinct is to take them straight to theater. You want to open the elbow and put that puzzle back together with absolute mechanical precision.
Oh, absolutely. I mean, it is a phenomenal psychological hurdle. We are fundamentally trained to fix broken things. You see a break, you fix it.
Exactly. But what if the strongest, most robust clinical evidence we have today tells you that the absolute best medical treatment is, well, to put them in a simple sling, send them home, and effectively do nothing?
Yeah. And you are entirely correct to highlight that. We are currently living through one of the most radical paradigm shifts in upper limb trauma. The bone is broken, yes, but our traditional urge to fix it is actually what might be causing the most harm.
Which is wild to think about. Welcome to Deep Dive Ortho. Today, we are completely tearing up the traditional orthopedic playbook for Olecranon fractures. For decades, we relied on a standard, almost comforting algorithm.
Very comforting, yes.
But today, that algorithm is under heavy scrutiny. We are dealing with a perfectly accessible bone that creates a remarkably murky web of clinical decision-making. We are going to break down the landmark trials, the biomechanical failures of our classic techniques, and give you a clear, evidence-based framework for the ultimate debate in trauma.
The big one. When to fix, when to excise, and when to completely ignore.
Spot on. So let's start with the context. To truly grasp why this debate is so fiercely contested right now, you really have to visualize the anatomical paradox of the olecranon.
Yeah, it is a paradox. On one hand, it is deceivingly accessible. It sits totally subcutaneously at the proximal tip of the ulna. I mean, you can literally tap it with your finger right now as you're listening.
Right, there's practically no flesh over it at all.
Exactly. That lack of a protective muscle envelope is exactly why it is so vulnerable to direct impact, like falling backwards and catching your entire body weight on a bent elbow.
It takes the absolute brunt of the force.
It takes all of it. But you see, it is not just a passive bumper of bone. It is the anatomical keystone of the elbow. It is the direct insertion point for the massive triceps tendon, making it the entire foundation of the elbow's extensor mechanism.
And crucially, its anterior face forms the greater sigmoid notch, right?
Spot on. This perfectly contoured cartilaginous dish that wraps so tightly around the spool-like humeral trochlea, that tight articulation is what gives the elbow its inherent stability.
So it's not just a hinge.
No, not at all. So when you fracture the olecranon, you are not just snapping a bone, you are obliterating the extensor mechanism, you're destroying the articular congruity of a perfectly machined joint, and you are potentially destabilizing the entire arm.
Which brings us to the diagnostic foundation. Because treating this is certainly not a one-size-fits-all scenario anymore.
Far from it.
Before a surgeon even looks at a scalpel or a sterile drape, the fracture has to be accurately classified. And we aren't just talking about academic exercises to torment registrars on ward rounds, are we?
Definitely not. The classification you choose dictates the entire mechanical fate of the reconstruction. Let's look at the two titans here, the Mayo and Schatzker classification systems.
Let's start with Mayo. Why is that one so critical?
Well, the Mayo classification is arguably the most brilliant and clinically utilitarian system we use, specifically because it forces the surgeon to look past the obvious crack in the bone and assess the surrounding soft tissue envelope.
Right.
It evaluates three things: displacement, combination, and the absolute linchpin of elbow trauma ulnohumeral stability.
Okay, let's break that down for the listeners. What does a Mayo type I actually look like when they roll into the emergency department?
A Mayo type I is your classic undisplaced fracture. It might be a single transverse crack or it might be slightly comminuted, but the key is that the pieces haven't actually moved.
They're sitting where they belong.
Exactly. The triceps tendon expansion, that thick fascial sleeve that wraps around the bone, is largely intact. Because that sleeve is intact, the triceps can actually contract without pulling the bone ends apart.
Ah, so the joint remains perfectly concentric.
Spot on. For these, regardless of the patient's age, you generally treat them non-operatively with a brief period of immobilization.
So a type I is a structural crack, but the architectural integrity of the joint is safe. I imagine the trouble really starts when we hit type 2.
Precisely. A Mayo type 2 means the fracture is displaced. The gap between the bone ends is greater than 3 millimeters.
Which means the triceps has won the battle.
Yes, the pull of the triceps has physically overpowered the periosteum and distracted the fragments. However, and this is the crucial distinction, the ulnohumeral joint itself remains stable.
The collateral ligaments on the sides of the elbow are still holding on.
Exactly. The radial head is sitting perfectly in its joint. The anterior structures are still holding the elbow together. We subdivide this into type IA, which is a simple two-part fracture, and type IIB, which means there are multiple shattered fragments or comminution.
And then we step into the danger zone, the Mayo type 3.
Type 3 is an entirely different beast. It is a displaced fracture, but the defining feature is profound instability.
The structural integrity is just gone.
Completely gone. The elbow is actively subluxating or frankly dislocating on the radiograph. This tells you instantly that the energy of the injury was massive. It hasn't just broken the olecranon, it has torn through the collateral ligament complexes, or it has sheared off the coronoid process at the front of the joint.
So the joint is essentially just floating.
It is. And again, we divide this into IBI for non-comminuted and IB for comminuted.
Now, this is where I really want to push back a bit on how we use these classifications in the real world.
Go.
It feels like setting up a highly complex algorithmic sorting system. If you input bad data at step 1, the entire downstream treatment tree completely collapses.
Yes.
For instance, what happens if a busy, exhausted registrar looks at a radiograph at 2 in the morning, sees the displaced bone, but completely misses a subtle anterior translation of the ulna? They call type 3 a type 2.
It is a catastrophic error. And quite frankly, it happens more often than any of us would like to admit. If you misclassify a Mayo type 3 as a type 2, you will choose the wrong operation.
Because you think it's stable.
Exactly. If you think the joint is inherently stable, you might decide to use a simple tension band wire to pull the olecranon fragments together. But a tension band wire provides zero stability against anterior shear forces.
None at all.
Zero. It completely relies on the surrounding ligaments and the anterior bony buttress of the ulna to act as a solid foundation.
But in a type 3, that foundation is destroyed. So what actually happens to the patient?
Well, the patient wakes up from surgery, they start moving their arm, and because the ligaments are torn or the coronoid is missing, the entire ulna subluxates anteriorly. The tension band wire construct buckles under the shear stress, the articular surface collapses, and the fixation fails entirely.
Wow.
Recognizing instability isn't just an academic tick box. It is the most critical fork in the decision tree. A type 3 fracture demands rigid, heavy-duty plate fixation and often complex ligamentous repair just to hold the skeleton out to its normal dimensions.
So Mayo gives us this stability and displacement parameters. Where does the Schatzker classification fit into this? Are we just adding more acronyms for the sake of it, or does it give us fundamentally different mechanical data?
It's vital data. Schatzker gives us the geometry of the fracture line, which is the missing piece of the puzzle when you are trying to select your exact hardware in theater. Mayo tells you if you need to fix it securely. Schatzker tells you how the pieces will actually behave when you compress them.
Okay.
Schatzker defines transverse fractures, oblique fractures, comminuted ones, and fracture dislocations.
Why does the exact angle of the break matter quite so much?
Well, think about the physics of compression. If you have a pure, simple transverse fracture, a straight line across the bone, and you apply a wire loop to squeeze the ends together, the two flat, bony faces will meet flush.
They sit perfectly against each other.
Right. They compress perfectly. That is an ideal scenario for a tension band wire. But imagine the fracture line is oblique, running at, say, a sharp 45-degree angle.
If you squeeze an angled break, the pieces are just going to slide right past each other.
Exactly. You apply compression, and the proximal fragment simply shears down the slope of the distal fragment. The bone shortens, the articular surface creates a massive step-off, and the joint is ruined.
So what do you do instead?
An oblique Schatzker fracture pattern absolutely mandates interfragmentary lag screws. You have to drive a screw perpendicular to the fracture line to generate absolute stability and stop that sliding. And then you typically protect that screw with a dorsal plate.
Okay, so between Mayo and Schatzker, we have a very clear two-dimensional radiographic map of the bone. But here is my overarching concern with relying purely on these systems.
Let's hear it.
Do they actually account for the human being attached to the elbow? I mean, an 85-year-old with a Mayo-type IIA fracture has vastly different bone density, tissue quality, and daily functional demands than a 25-year-old professional athlete with the exact same X-ray.
You have hit on the exact limitation of purely radiographic classifications. They are structural maps, yes, but they tell you absolutely nothing about the biological envelope. They do not quantify osteoporosis. They do not warn you that in a frail elderly patient, a rigid stainless steel wire might simply slice through their osteoporotic bone like a cheese wire through butter the exact moment they flex their arm. The classification tells you what the bone looks like. It does not tell you how the bone will hold metal.
So you have to constantly overlay the patient's physiology onto the algorithm.
You must. It is the essence of clinical judgment. Take a severely comminuted Mayo-type IID fracture. If that is in a young manual laborer, you have no choice. You must perform an anatomical plate reconstruction.
Because they need that perfect joint surface.
Exactly. Opening the joint, piecing together the articular cartilage perfectly to prevent early onset osteoarthritis. But that exact same comminuted Mayo IAB in a low-demand octogenarian with paper-thin bone.
You wouldn't put a plate in that.
Trying to plate that is a fool's errand. You will strip the blood supply, the screws won't hold, and the wound simply won't heal. That patient is a prime candidate for excising the fragments entirely or, as we will discuss shortly, putting them in a sling and avoiding the operating theater altogether.
Well, let's get into the surgical techniques themselves, starting with the absolute traditional workhorse, tension band wiring, or TBW. For decades, if you said Olecranon fracture, the automatic reflex was tension band wire.
It was the gold standard for a very long time.
And the mechanical theory behind it is beautiful. It's based on Pohl's principles. Can you explain how it conceptually converts a destructive force into a healing force?
It is a stunning piece of biomechanical reasoning. The olecranon sits at the posterior aspect of the elbow, which makes it the tension side of the joint. When your triceps muscle fires to straighten your arm, it pulls violently on the proximal olecranon.
And if the bone is broken transversely, that triceps pull physically distracts the fracture, just tearing the pieces apart.
It's actively fighting the healing process. So the genius of the tension band wire is that it harnesses that exact enemy force and turns it into an ally. The surgeon places two rigid K-wires down the length of the bone to hold alignment.
Like internal splints.
Exactly. Then they take a flexible stainless steel wire, pass it through a drill hole in the stable ulnar shaft, and loop it in a figure-of-8 pattern over the posterior surface of the olecranon, anchoring it behind the K-wires.
So you essentially have a metal wire loop sitting right on the back of the elbow.
Yes. And when you tighten that loop, it acts as a tension band on the posterior cortex. Now, when the patient bends their arm and the triceps pulls, the tension band resists the distraction.
Because the posterior cortex physically cannot pull apart anymore.
Spot on. The force is translated through the bone to the anterior cortex, the articular surface, and compresses the fracture firmly together. You are literally using the patient's own muscle contractions to squeeze the broken bone together, promoting primary bone healing.
It sounds flawless on paper.
Yeah.
A perfectly elegant biomechanical loop.
On paper, yes.
But then we actually look at the clinical reality. And the landmark data, particularly the deep dives done by Hume and Wyss, paint a frankly horrific picture of what happens after the patient leaves the hospital.
It's a sobering reality check.
They highlighted a staggering complication rate, specifically, a massive 50 to 80% hardware removal rate.
Wait.
Let's just pause on that number for a second.
It is shockingly high.
If a surgical technique requires an 80% secondary operation rate just to dig the metalwork back out of the patient's arm, why on earth are we still doing it? What is physically failing under the skin?
It is the biological reality violently colliding with the mechanical theory. The fundamental flaw is the anatomy of the proximal ulna. As we discussed, the olecranon has almost zero soft tissue cover.
Just skin and bone.
Skin, a whisper-thin layer of subcutaneous fat, a bursa, and then bone. There is no thick muscle belly to act as a cushion, so you are placing rigid, sharp metal directly under the skin at the exact point of the elbow that a patient rests on a desk.
Ouch.
Exactly. You have two rigid K-wires and a bulky, twisted stainless steel knot sitting subcutaneously. It causes profound chronic mechanical irritation. But unfortunately, it gets worse.
How so?
The biomechanics of the elbow actually work to dismantle the hardware. The triceps tendon isn't just a static strap. It dynamically loads the joint thousands of times a day. Every time the triceps pulls, it tugs at the proximal ends of those K-wires.
Even if you bury them.
Despite our absolute best surgical efforts to bury the wire ends deep into the triceps fascia or bend them over 180 degrees, the cyclical loading creates micromotion. Over weeks and months, those sharp K-wires slowly back out proximally.
I've actually seen this in clinics. It looks medieval. The wires actually tent the skin from the inside.
They tent the skin, they trigger massive painful bursitis, and in severe cases, they actually perforate the skin entirely, which creates an open track straight down to the fracture site.
Which is a catastrophic infection risk.
Absolutely massive.
That completely changes the informed consent process, surely. When you are consenting a patient for a TBW, you can't just list hardware irritation as a rare passing possibility.
No, you can't.
You basically have to tell them, I'm going to fix your broken arm today, but there is a flip of a coin chance, or worse, that we will be back in theater in a year for another general anesthetic just to take the metal out. That is a massive physiological and economic burden.
It is an unacceptable burden for routine cases, and it is exactly why the orthopedic community has rapidly pivoted away from tension band wiring as the default answer. We have to be incredibly selective now.
But I still see it being performed, and some senior surgeons defend it passionately. Is that just entrenched surgical dogma, or are there specific scenarios where the tension band is genuinely still the gold standard?
It is a bit of dogma, yes, but it also remains an excellent, cost-effective technique when used in the perfect indication.
Which is?
The ideal scenario is a young patient with a simple, perfectly transverse, uncomminuted fracture, a pure Mayo-type IIA, with phenomenal bone density. In that specific microenvironment, the bone is strong enough to hold the hardware, and the fracture geometry perfectly supports the tension to compression conversion.
And what about the technical tweaks? How do modern surgeons stop the wires from migrating?
Well, experienced trauma surgeons have evolved the procedure significantly. The biggest change is the trajectory of the K-wires. Historically, surgeons drove them straight down the intramedullary canal of the ulna.
Right down the middle.
But the canal is wide and hollow. The wires have no bony purchase to grip onto, so they easily slide backward. Today, the technique requires directing the wires slightly anteriorly, aiming to penetrate the thick, solid anterior cortex of the ulnar shaft, just distal to the coronoid.
So they bite into the hard bone.
Exactly. This bicortical purchase acts like an anchor, drastically increasing the pullout strength. Furthermore, instead of using thick stainless steel wire for the figure of 8, which leaves a huge knot, many surgeons now use heavy-duty braided non-absorbable sutures like fiber wire.
So you get the tension without the lump.
Spot on. It provides incredible tensile strength but lies completely flat, eliminating the bulky knot prominence.
But even with a perfectly executed, modernized TBW, if the fracture is comminuted, if it's in multiple pieces, the tension band concept just falls apart, right?
Completely. Yeah.
Because you have no solid bone to compress against. And that brings us to the massive modern shift in upper limb trauma, plate fixation. We're moving from dynamic wire loops to absolute rigid structural control.
It's been a game changer.
Let's get into the indications for plating, particularly pre-contoured locking plates and the concept of bridge plating.
The advent of anatomically pre-contoured locking plates has completely revolutionized how we handle complex, high-energy elbow trauma. To appreciate this, you really have to understand the nightmare it used to be.
Oh, the old standard plates.
Yes. Historically, if a surgeon needed to plate an olecranon, they would take a flat, straight piece of metal, a 1/3 tubular plate, and literally try to bend and twist it with heavy pliers in the operating theater.
Trying to match the patient's bone shape on the fly.
Exactly, trying to match the complex valgus bow and proximal curve of the ulna while the patient lay open on the table. It was tedious, and frankly, it was rarely a perfect fit.
It sounds like trying to do blacksmithing in the middle of a sterile field.
It essentially was. But today, the plates are 3D engineered based on thousands of anatomical CT scans. They are pre-contoured to perfectly match the normal anatomy of the proximal ulna right out of the packet.
That's incredible.
Furthermore, they feature proximal extensions, little metal tines or prongs that wrap around the very tip of the olecranon, designed specifically to capture the tiny fragments of bone right where the triceps tendon inserts.
The clinical data really backs up this shift, doesn't it? The findings from Bailey and other comparative trials provided a massive paradigm shift when comparing plate fixation versus tension band wiring for displaced fractures.
The data overwhelmingly demonstrated that in the presence of any combination, A Mayo-type IIB or IIB plating is mechanically and clinically vastly superior.
Why does it beat the wiring so soundly in those cases?
Well, if you have a comminuted fracture, the anterior bony buttress is shattered. If you try to use the tension band wire, the construct has nothing to squeeze against. As the triceps pulls, the fragmented pieces simply telescope into one another.
They just collapse.
Yes. The bone shortens, the joint surface develops massive step-offs, and the patient is guaranteed to develop severe, painful post-traumatic arthritis.
So the plate changes the physics entirely.
Exactly. A rigid locking plate acts as an internal fixator. It does not rely on the broken bone to provide any stability whatsoever. The plate itself bridges the gap. It is a load-bearing structure.
It's taking all the force.
All of it. It holds the bone out to its exact anatomical length, maintains the rotation, and rigidly supports the articular cartilage while the bone heals secondarily beneath it.
I love the analogy of bridge plating for this. Tension band wiring is like a dynamic suspension bridge that requires the ground on both sides to be perfectly solid.
Right.
But bridge plating a comminuted fracture is like building a heavy-duty steel overpass across a gorge when the ground itself is crumbling. You don't try to glue the crumbling gorge back together, you just bypass it entirely.
That is a brilliant way to conceptualize it. And bypassing the crumbling gorge is not just a mechanical trick. It is profoundly important for the biology of healing.
Because of the blood supply.
Yes. In a severely shattered fracture, if a surgeon tries to open up the fracture site completely, dig through the fragments, and use tiny screws to piece every single millimeter of bone back together, they will strip the periosteum.
Where the blood lives.
They will tear away all the tiny blood vessels supplying those fragments, and they will wash away the fracture hematoma.
And the fracture hematoma isn't just bruised blood, is it? It's the biological soup that actually heals the bone.
Precisely. It is packed with osteoprogenitor cells, cytokines, and growth factors. It is the liquid blueprint for new bone. The principle of bridge plating is elegant in its restraint.
You just leave the fragments alone.
You make an incision proximally and an incision distally. You secure the plate to the solid intact bone above the shatter zone and the solid intact bone below the shatter zone. You do not touch the comminuted fragments.
Wow, you just let the body do its job underneath the plate.
You leave that pristine biological environment totally undisturbed. The plate provides the rigid mechanical stability required, and the untouched biology does the healing.
Now, you mentioned the locking screw technology earlier. Why is that specific feature so critical, especially when we're dealing with older patients or softer bone?
It is a total game changer. In a conventional, old-school plate, the screw relies entirely on friction. As you tighten the screw, it pinches the plate down hard against the bone.
Like a normal wood screw.
Exactly. But if the bone is osteoporotic and soft, the thread of the screw simply strips out the bone as you try to tighten it. It's like trying to put a standard screw into wet drywall. It just spins and fails.
But a locking screw is fundamentally different.
Yes. In a locking plate, the head of the screw actually has fine threads on it, and the hole in the plate also has threads. As the screw is driven in, the head of the screw physically threads into and locks onto the plate itself.
So it becomes one solid piece of metal.
It creates a fixed angle construct.
Yeah.
The screw becomes a rigid, immovable post attached to the plate. It doesn't rely on pinching the bone to stay stable. Even in incredibly poor quality osteoporotic bone, the screws cannot toggle, angulate, or back out.
That's incredibly secure.
It provides such a phenomenally stable construct that we can allow the patient to start aggressively moving their elbow almost immediately after surgery.
But there's no free lunch in orthopedics. Plating provides incredible rigid fixation, but we are talking about putting a massive piece of titanium on the bone.
Yes, we are.
It requires a much larger surgical footprint. You have to strip away more soft tissue to get the plate to sit flush on the dorsal surface of the ulna. And while the sharp K-wires of a tension band might be gone, you still have the blunt reality of hardware prominence.
You are absolutely correct. It is a significant trade-off. To seat a long pre-contoured plate properly, you have to elevate the impernious muscle laterally and mobilize the flexor carpi ulnaris medially.
That's a lot of dissection.
This extensive dissection trauma significantly increases the risk of heterotopic ossification, where the body erroneously forms new bone in the soft tissues around the joint and soft tissue adhesions. Both of these can severely restrict the elbow's range of motion post-operatively.
And patients still complain about the metal, don't they?
Oh, they do. The hardware removal rate for plates is substantially lower than for tension bands. It sits around 10 to 20% rather than 80%, but it is definitely not zero.
It's still a chunk of metal under thin skin.
Modern plates are low profile, but a thick slab of titanium sitting on the subcutaneous border of the ulna is still highly palpable. Thin patients often find it incredibly painful to rest their elbows on a table or an armrest. So you are trading the acute, sharp, piercing irritation of a migrating K-wire for the blunt, dull, chronic prominence of a plate.
Okay, so we have the tension band wire for the simple transverse breaks and the heavy-duty plate for the comminuted unstable ones.
Right.
But what happens when the fracture is so utterly catastrophic, the bone basically resembles crushed eggshells that no screw or wire will ever hold it together? Or, conversely, what if you're looking at an 80-year-old patient who barely leaves the house, and the thought of a massive 2-hour anatomical reconstruction with a huge metal plate just seems like cruel and unusual punishment?
That is where we pivot.
We step away from adding metal, and we move to the minimalist approach. Fragment excision and triceps advancement.
I am incredibly passionate about this technique. Fragment excision is a highly elegant, highly effective, and deeply underutilized fallback in the trauma surgeon's armamentarium.
Why do you think it's underutilized?
Because it relies on a philosophy of subtraction rather than addition. We are completely eliminating the risk of hardware failure, wire migration, and metal prominence by the simple virtue of using absolutely no hardware at all. We take the broken pieces of bone and we simply throw them in the bin.
It sounds totally wild to just throw away a piece of the joint. Who is the ideal candidate for this?
The indications are specific and must be respected. It is for elderly patients with osteoporotic bone that won't hold screws. It is for severe, crushing comminution that defies any mechanical attempt at fixation. And most importantly, it is for patients with low functional demands.
So not your 25-year-old athlete.
Absolutely not. A patient who primarily needs their elbow for basic activities of daily living, eating, dressing, personal hygiene, reading a book, does not require the absolute anatomical perfection of the articular surface that a young bricklayer requires.
But there is a massive catch. There is an absolute, non-negotiable biomechanical rule governing this procedure.
There is.
You cannot just saw off the entire proximal ulna and expect the arm to work. The rule dictates that you must never excise more than 50% of the olecranon. Why is that specific invisible line of the bone so critical to preserving both the triceps lever arm and the entire stability of the elbow joint?
That 50% boundary is the absolute crux of the operation. If you cross it, the elbow is destroyed. To understand why, we have to look incredibly closely at the anatomy of the greater sigmoid notch, the C-shaped articular dish of the ulna.
Okay, picturing a C shape.
The olecranon forms the top proximal half of this dish, and the coronoid process forms the bottom distal half.
And they cup the humerus between them.
Exactly. Now, look at the collateral ligaments, the thick bands of tissue on the inside and outside of the elbow that prevent it from wobbling side to side. The medial and lateral ulnar collateral ligaments insert distal to the midpoint of the olecranon.
Okay.
The anterior bundle of the medial collateral ligament, which is the absolute primary stabilizer resisting valgus stress, inserts on a tiny bump called the sublime tubercle right at the base of the coronoid.
So the ligaments attach lower down on that C shape.
Yes. So if you excise the proximal 30 or 40% of the olecranon, the top of the C, you are removing bone, but you are not detaching those critical stabilizing ligaments. The joint remains perfectly stable.
But if you go too far,
If you violate that 50% rule and aggressively excise 60 or 70% of the bone, your saw blade physically cuts away the insertion points of the primary stabilizing ligaments.
and what physically happens to the kinematics of the arm when you cross that threshold on the operating table?
The elbow simply falls apart. Without the deep cupping effect of the proximal olecranon to lock it in place, and without the restraint of the collateral ligaments to tether it, the powerful pulling forces of the brachialis and biceps muscles at the front of the arm will simply yank the entire ulna forward.
Oh, wow.
The elbow will subluxate or completely dislocate anteriorly relative to the humerus. You turn a manageable fracture into a chronically dislocated, useless limb.
That is terrifying. But what about the triceps? The triceps was attached to the bone you just threw away in the bin. How does excising the bone affect the patient's ability to actually straighten their arm?
This is the second half of the biomechanical puzzle, the lever arm. The olecranon acts as a bony fulcrum. It sits slightly posterior to the axis of rotation of the elbow joint, giving the triceps muscle a massive mechanical advantage to extend the forearm.
So as you cut bone away,
As you excise more and more bone, you are physically shortening that fulcrum. The triceps tendon has to be dragged further and further distally down the ulnar shaft to find a place to be reattached.
you are fundamentally changing the leverage geometry.
Exactly. You shorten the moment arm, the muscle loses its mechanical advantage. Excising up to 50% shortens the fulcrum, but it preserves just enough of the moment arm for functional extension strength.
So the patient can still straighten their arm.
Yes, but if you excise more than 50%, the geometry fails entirely. It results in a profound, disabling extensor lag. The patient will ask their brain to straighten their arm, the triceps will fire with all its might, but they will be physically unable to extend the elbow against the pull of gravity. It is a devastating functional loss.
So, assuming you have safely stayed within the 50% limit, the surgical technique of triceps advancement isn't just loosely sewing the tendon back to the bone, is it? It has to be an incredibly robust mechanical reattachment. You are practically recreating the extensor mechanism from scratch. How is this meticulously executed in theater?
The technique demands precision and absolute biological respect. Once the shattered bony fragments are sharply dissected out and excised, you are left with a raw, flat edge of proximal ulna. You must first use a burr or a rasp to smooth this remaining articular edge down, rounding it off.
Because you don't want a sharp edge in the joint.
Spot on. If you leave a sharp bony corner, it will act like a chisel and aggressively abrade the cartilage of the humeral trochlea every single time the patient bends their arm, leading to rapid, painful arthritis.
You have to bevel the edge perfectly.
Yes, bevel it perfectly smooth. Then you turn your attention to the triceps tendon. It is a massive, thick structure, now completely detached from its native footprint. We mobilize it to ensure it can reach the remaining bone without excessive tension.
How do you secure something that thick?
We take incredibly heavy, non-absorbable sutures and weave them through the distal end of the tendon using a Krakow or a Bunnell locking stitch pattern. These stitches grasp the tendon fibers so tightly that they will not tear out under load.
And how do you anchor that to the bone itself?
We drill multiple small transosseous holes directly into the dorsal cortex of the remaining ulnar shaft, positioned just distal to the articular surface. We pass the heavy sutures through these drill holes and tie them down under immense tension.
Pulling the tendon right down under the bone.
This physically pulls the raw edge of the triceps tendon tightly down onto the freshly decorticated bone. By pressing the tendon firmly against bleeding bone, we create the perfect biological environment for tendon-to-bone healing to occur over the next 6 weeks.
This leads me to an incredibly incisive question about the intraoperative reality. You are standing in theater, you have excised the fragments, and you are staring at the remaining bone. Is there a reliable, objective intraoperative test to guarantee you haven't crossed that 50% line and compromised the joint? Or are you entirely reliant on eyeballing it and hoping the preoperative X-ray templating was accurate?
Eyeballing it is notoriously dangerous, particularly when the anatomy is distorted by massive trauma and soft tissue swelling. You absolutely must objectively test the stability on the table before you commit. Once you have excised the fragments, but critically, before you secure the triceps tendon, you perform a dynamic stability test under live fluoroscopy real-time X-ray.
What does that actually look like in practice?
You manually take the patient's elbow through a full passive arc of motion, from full extension to deep flexion, while simultaneously applying aggressive varus and valgus stress, actively trying to twist the joint open. You stare at the X-ray monitor the entire time.
And what are you looking for?
If the joint remains perfectly concentric, with the remaining ulna tracking flawlessly around the humerus throughout the entire arc, you've safely respected the boundary. You can confidently proceed with the triceps advancement.
And if it doesn't? What if you see the joint gap open up?
If you see the joint space widen on the monitor, or if the ulna begins to translate or subluxate anteriorly, your stomach drops. You have compromised the primary stabilizers. At that point, excision is immediately off the table. It is no longer a viable option. You must immediately pivot to a complex, massive reconstruction using plates and bone grafts. Or, in an elderly patient, you might have to convert to a total elbow arthroplasty, a full joint replacement right then and there.
That is an incredibly high-stakes pivot. But as complex and elegant as excision is, recent high-level clinical evidence has shaken the foundation of orthopedic trauma even further. It has forced us to ask an even more radical question. Should we be operating on certain demographics at all?
This is the big one.
We are moving into the elderly patient conundrum. The ultimate debate of fix, excise, or completely ignore. Let's explore the emerging paradigm-shifting evidence for non-operative management in the elderly.
This is, without exaggeration, the most significant shift in our approach to upper limb trauma in the last decade. Historically, the unbreakable dogma taught to every orthopedic registrar was simple. A displaced olecranon fracture means a loss of the extensor mechanism. Therefore, it absolutely mandates surgery to restore continuity,
Regardless of age.
regardless of whether the patient is 20 or 95. But we have to look closely at the recent randomized controlled trials. Specifically, the groundbreaking work led by Duckworth and colleagues, and the subsequent guidelines published by the British Orthopaedic Association and NICE.
The Duckworth trials were truly a revelation. They directly challenged the surgical dogma. They took a cohort of patients, typically over the age of 75, who all had displaced olecranon fractures, and they randomized them. Half got the standard operative management, predominantly tension band wiring or plating, and the other half got completely non-operative management.
Yes.
What exactly did the expert analysis of this data reveal at the 1-year mark?
The medical community was stunned. The primary outcome measures in these trials weren't just x-rays. They were rigorous, patient-reported functional scores. They used the DSH score disabilities of the arm, shoulder, and hand, and the Oxford elbow score, alongside tracking complication rates.
And the results?
The results were irrefutable. At 1-year follow-up, there was absolutely no statistically significant difference in functional outcomes between the surgically managed group and the non-operatively managed group.
Wait, let me make sure I'm understanding the magnitude of this. The elderly patients who were given a sling, sent home, and never saw the inside of an operating theater had the exact same functional capacity, the exact same range of motion, and the exact same pain scores as the patients who underwent a complex 2-hour surgical fixation with plates and screws.
Exactly the same functional outcome.
But surely the complication profiles between the two groups were vastly different.
That is the pivotal point, and it is what tips the scales entirely. The complication rates in the surgical cohort were substantial, as we expect in frail, elderly populations. We saw deep wound infections requiring washouts, hardware prominence requiring secondary removal surgeries, catastrophic wound breakdowns due to thin skin, and iatrogenic neuropathies.
And the sling group?
The non-operative group, by virtue of avoiding the scalpel entirely, bypassed all of these surgical complications. They had 0 infections, 0 nerve injuries, 0 hardware failures.
So what does conservative management actually look like in practice for these patients? If you are leaving a displaced fracture alone, you aren't just putting them in a heavy plaster cast for 6 weeks, are you?
Absolutely not. Putting an elderly elbow in a rigid cast for 6 weeks would guarantee severe, irreversible arthrofibrosis stiffness. Conservative management in this context relies on early motion.
Right.
It involves a very brief period of immobilization, typically just a simple collar and cuff sling or a resting splint, strictly for acute pain relief, lasting only a few days to a maximum of a week.
And then you tell them to move a broken arm.
Yes. The moment the acute swelling subsides, you instruct them to begin early, active mobilization as tolerated by their pain. You want them gently bending and straightening the elbow.
But anatomically, what is happening under the skin? If the bones are displaced by a centimeter, they aren't going to magically pull back together and heal with solid bone, are they?
No, they do not. Anatomically, the fracture does not heal with bony union. It heals with what we call a fibrous non-union. The fracture fragments remain radiographically displaced forever.
So the gap stays there.
If you take an x-ray at 6 months, the gap is still there, sometimes a centimeter or 2 wide. But biologically, the body bridges that gap with incredibly dense, thick, fibrotic scar tissue.
And this is the most counterintuitive, mind-bending part for many surgeons and patients to grasp. A radiographic non-union, an x-ray that looks absolutely terrible with bone ends sitting far apart, does not equate to a poor clinical outcome for an 85-year-old. The x-ray looks like a failure, yet the patient is functioning perfectly well in their daily life.
It forces us to remember the golden rule of medicine. We treat the patient, not the radiograph. That dense, fibrous scar tissue becomes remarkably strong enough to reliably transmit the pulling force of the triceps muscle across the gap to the ulna. Now, the mechanics aren't perfect. The patient will almost certainly have a slight extensor lag. Because the triceps is slightly lengthened by the gap, they might not be able to actively straighten their arm the final 10 or 15 degrees against gravity.
But does lacking 15 degrees of terminal extension actually matter?
Well, for a professional gymnast, it is a career-ending disability. But for an elderly, low-demand individual lacking 10 degrees of terminal extension has absolutely zero impact on their ability to feed themselves, brush their hair, dress themselves, or pour a kettle. The functional deficit is entirely subclinical in their daily routine.
Which brings up a massive sociological question. How do we define elderly and low demand in the modern era?
It's getting harder.
We're living in a time where chronological age is entirely uncoupling from physiological age. You have 80-year-olds who are frail, sarcopenic, and homebound.
Yeah.
But you also have 80-year-olds who are playing competitive club tennis, swimming daily, and lifting weights. You can't just use an arbitrary birthday to make this call.
You absolutely cannot use an arbitrary cutoff like age 75. It requires a highly nuanced, holistic assessment. You must evaluate physiological frailty, bone density, cognitive status, can they follow rehabilitation instructions, and, crucially, their specific functional demands.
So the tennis player.
Take your 80-year-old tennis player. If they sustain a displaced olecranon fracture, a fibrous non-union with a 15-degree extensor lag will ruin their serve and severely impact their quality of life. They likely require a surgical fixation, perhaps an anatomical plate, to restore the rigid skeletal anatomy necessary for forceful overhead athletic activity.
But the frail 75-year-old.
A 75-year-old with severe Parkinson's disease, osteopenia, and high anesthetic risk is the quintessential candidate for non-operative management. The assessment of demand is deeply personal. It requires sitting down with the patient, understanding exactly what they need their elbow to do on a Tuesday morning, and managing their expectations.
But let's be honest about the psychology of the surgeon here. Orthopedic surgeons are fundamentally wired, by their very training and personality types, to fix broken things.
We are.
When a trauma surgeon looks at a massively displaced intra-articular fracture, every instinct, every year of their training screams to reduce it, clamp it, and plate it. Is the hardest part of conservative management actually convincing the surgeon to sit on their hands and tolerate an ugly x-ray rather than convincing the patient that surgery isn't needed?
It is a profound psychological struggle for the surgeon. We are interventionists by nature. It genuinely feels like a failure of duty, a failure of care, to look at a displaced fracture, look the patient in the eye and say, we are going to do nothing.
It goes against the grain.
Completely. It takes immense clinical maturity and confidence in the literature to recognize that sometimes the most aggressive and beneficial intervention is restraint. The surgeon has to learn to silence their ego and tolerate a chronically ugly radiograph.
And communicating that to the family must be an absolute minefield.
It is equally challenging. The patient and their family arrive at the emergency department terrified, in pain, expecting a fix. They expect a cast or an operation. You often have to spend significantly more time explaining the complex rationale for non-operative management than you would spend simply consenting them for surgery.
Really mapping it out for them.
You have to clearly, emphatically articulate that the risks of a general anesthetic, the high risk of deep infection, and the likelihood of needing a second operation to remove metalwork far outweigh the theoretical benefit of making the bone look perfect on a screen.
But regardless of whether we decide to wire the bone, plate the bone, excise the fragments, or completely ignore the fracture, every single pathway carries risk. There is no free lunch in elbow trauma.
None at all.
We must finally address the universal specter of complications that haunt the management of the olecranon. Let's synthesize the major complications across all treatment modalities. We've heavily covered hardware prominence and the removal rates. But let's look at the neurological risks. The ulnar nerve is the absolute landmine in this region.
The complication profile is precisely what makes the elbow such an unforgiving, challenging joint for surgeons, and you are exactly right to highlight the neurological risk. The ulnar nerve is without question the most vulnerable, high-stakes structure in the vicinity of the olecranon.
The ulnar nerve seems like the unwelcome third wheel in elbow trauma. It is constantly sitting right there, just millimeters away from our retractors, at constant risk of being irritated by our well-intentioned hardware. It seems to dictate the surgical approach almost as much as the bone itself.
It is an incredibly unforgiving nerve. To understand its vulnerability, you have to trace its anatomy perfectly. The ulnar nerve descends the arm and passes directly posterior to the medial epicondyle of the humerus, the bony bump on the inside of your elbow.
Oh, funny bone.
Precisely. It runs right through a tight anatomical tunnel called the cubital tunnel. In this space, it is literally subfacial. It is lying right against the periosteum of the bone with almost no padding. It then enters the forearm by diving tightly between the two heads of the flexor carpi ulnaris muscle.
So it's perfectly positioned to be in the way of absolutely everything we do.
Exactly. When you are operating on the olecranon, whether you are placing a long plate along the medial border of the ulna, drilling blindly from proximal to distal for K-wires, or aggressively retracting the soft tissue sideways to expose a fracture for excision, the nerve is right in the line of fire.
So how does an expert trauma surgeon protect it intraoperatively? Do you routinely dissect it out and look at it so you know it's safe?
Well, that is a subject of great debate. In routine olecranon fractures, the nerve is generally not formally dissected out or explored. The act of dissecting the nerve, stripping away its surrounding fat, can actually devascularize it or cause perineural scarring, creating a neuropathy where none existed.
So looking for it can actually damage it.
Yes, however, the surgeon must be acutely, obsessively aware of its location at all times.
How do you damage it without seeing it?
Easily. If you are placing a medial plate, you are working right on the border of the cubital tunnel. A misplaced drill bit that plunges a few millimeters too far medially can instantly sever the nerve, or the drill flutes can catch the nerve and wrap it around the bit, completely ripping it apart.
Oh, that's a terrifying thought.
Furthermore, if K-wires are placed too far medially, or if they migrate medially over time, they can cause chronic, devastating friction. But it's not just surgical risk. Even in non-operative management, a massive fracture hematoma expanding within the tight cubital tunnel or excessive bony callus formation as the fracture tries to heal can physically compress the nerve.
What is the patient experience if that happens?
If a patient presents in the clinic postoperatively or during non-operative management with new onset numbness, tingling, or pins and needles specifically in their small finger and the ring finger, or if they start losing the intrinsic muscle power to spread their fingers apart, you must have a critically high index of suspicion for iatrogenic ulnar nerve compression or irritation.
You can't just hope it goes away.
You cannot ignore it. It often requires urgent surgical decompression.
Beyond the nerve, we have to talk about the battle against elbow stiffness. The elbow joint is notoriously aggressively unforgiving to prolonged immobilization. Why is the elbow capsule so prone to stiffening up compared to, say, the wrist or the ankle? And how do you balance the need for fracture stability with the absolute necessity of early range of motion?
The elbow capsule is quite unique. It is highly vascular and densely, richly innervated. Following significant trauma or the secondary trauma of a surgical incision, there is an aggressive, explosive inflammatory response. The joint rapidly fills with blood, forming a tense hemarthrosis.
Right.
Now, if the elbow is kept immobilized in a rigid cast, this hematoma doesn't just dissipate, it organizes.
It turns into scar tissue.
Exactly, and incredibly rapidly. The blood clots, fibroblasts invade, and it turns into dense fibrotic scar tissue. The capsule thickens, contracts, and shrinks around the joint. The patient develops severe arthrofibrosis.
Which is very hard to undo.
Incredibly hard. And here is the clinical reality. A stiff, contracted elbow that cannot bend enough to reach the mouth or extend enough to reach the perineum is often vastly more disabling to a patient than a mildly painful or slightly misaligned elbow.
So the entire goal of surgical fixation, the massive plates, the tension band wires, all the metalwork, is not just to hold the bone together for healing. The real ultimate goal is to provide a mechanical construct that is absolutely stable enough to withstand immediate aggressive movement.
You have hit the nail on the head. That is the core philosophy of modern trauma surgery. Absolute stability for early active mobilization. If a surgeon spends 2 hours placing a beautiful plate on an olecranon, but they are not confident enough in their mechanical fixation to let the patient bend the elbow the very next morning, the surgery has failed its primary functional objective.
You genuinely want them moving on day one.
We aim for patients to begin active, assisted range of motion exercises within 24 to 48 hours postoperatively. We work intimately with the physiotherapy team to ensure they are immediately pushing the boundaries of both flexion and extension, forcefully preventing that highly reactive capsule from contracting down and freezing the joint.
And finally, let's address non-union. We discussed fibrous non-union earlier as a perfectly acceptable, even desired outcome in the elderly non-operative cohort.
Yes.
But in a younger, surgically managed patient, say a 40-year-old who had a plate put in, when does a non-union actually require a major revision intervention versus when is it merely a radiographic annoyance that you just observe?
That distinction is entirely clinical, driven by the patient's symptoms, not the X-ray. A radiographic non-union, where you take an X-ray at 6 or 9 months and you still see a dark, persistent radiolucent line entirely across the fracture site, is only a medical problem if it is symptomatic.
So if they feel fine, you leave it alone.
If that 40-year-old patient has full, painless range of motion, full triceps power, and no discomfort during their daily life, we do not operate on the X-ray. We simply observe it. The implant is acting as a permanent internal splint, and the patient is functioning perfectly.
But what it hurts?
It If the patient has sharp pain directly over the fracture site with active extension against resistance, a profound sense of weakness, or if we start seeing the hardware actually failing screws backing out, or the heavy titanium plate literally snapping in half due to the relentless cyclical loading across an unhealed fracture gap, that is a symptomatic structural non-union.
And fixing that is a massive undertaking, I assume.
It is a major, complex revision operation. We must reopen the entire surgical site, painstakingly remove all the broken hardware, and then aggressively debride the fracture.
Cleaning out the dead tissue.
Exactly. The bone ends in a non-union becomes sclerotic dead, hard, vascular bone. We have to use a burr or a saw to cut back to healthy, bleeding, biologically active bone. We then must insert structural bone graft, often a block of bone harvested from the patient's own iliac crest in their pelvis, to span the gap.
Wow, so taking bone from the hip.
Yes. Finally, we apply a massive, heavy-duty revision plate construct, often with compression techniques, to completely restart the biological healing process from day zero. It's an operation we desperately want to avoid, which is exactly why getting the initial fixation right is paramount.
We have covered an immense amount of ground today, navigating from the initial biomechanics of a simple fall to the most complex salvage procedures and paradigm-shifting clinical data. To synthesize this deep dive, let's distill the absolute most memorable clinical pearls for the listener to take back to their practice tomorrow morning.
Let's do it.
First, when you are considering a tension band wire, you must counsel the patient aggressively and honestly at the absolute outset regarding the 50 to 80% hardware removal rate. Do not let a second operation be a surprise to them 12 months down the line.
Absolutely essential.
Second, for young patients with comminuted, high-energy fractures, the data is unequivocal. Anatomic, pre-contoured locking plating provides vastly superior mechanical stability and clinical outcomes compared to any wiring technique.
Unquestionably.
Third, if you are performing a fragment excision in a low-demand patient, you must strictly respect the 50% rule. If you excise more than half of the olecranon, you completely destroy the triceps lever arm, sever the collateral ligament insertions, and invite catastrophic ulnohumeral dislocation.
Never cross the line.
And finally, the most radical shift of all. Based on the Duckworth data, we must actively embrace conservative, completely non-operative management for the elderly, low-demand patient. A fibrous non-union is often a highly functional, completely complication-free outcome.
Those four pillars form a robust, modern, deeply evidence-based algorithm. If you assess the stability meticulously via the Mayo classification, fiercely respect the soft tissue envelope, protect the ulnar nerve at all costs, and precisely tailor the exact intervention, or lack thereof, to the physiological age and demands of the unique patient sitting in front of you, you will navigate these diagnostic and surgical muddy waters with exceptional competence and deliver phenomenal care.
If you found this deep dive valuable for your clinical practice, please take a moment to rate and share this program with your orthopedic colleagues. We leave you with a final, forward-looking thought to mull over. If robust clinical evidence now definitively proves that conservative management is functionally equivalent to complex surgery for the elderly today, will our definition of elderly or low demand inevitably shift downwards in the next decade?
It's a fascinating question.
Are we on the cusp of realizing that the human body's capacity for fibrous functional adaptation is far greater than our surgical desire to rebuild it? Are we on the verge of rendering even more of our standard, historically revered surgical interventions completely obsolete? Thank you for joining us today.